So when you're young, those lifestyle type cycling will be sufficient to control mTOR. Uh, that's, I guess there's a question in there. Is that correct? But as we get older, is there things that we can take, like rapamycin, that would help with the cycling? And
Right.
would you see that is that one of the ways that we would use rapamycin?
Correct. Yeah. So yeah, I think we probably get multiple different points of view on that. Is it age alone that causes mTOR? We'll call it resistance, or is it years? And that's always the conundrum that we have to sort of face. Partly aging, but partly if you sit in a chair for 30 years, you know, and even if you, it's the time in the chair, not necessarily getting older that
Hmm.
would cause pain. So yeah, so rapamycin is there's many tools that we can utilize, from fasting to cold hormesis to breathing techniques to whatever we need to do to make that mitochondria, because we're talking about mitochondrial function
Mhm.
and resilience. So it's sensing energy for the cell. Um, Rapamycin is a tool that's going to obviously suppress mTOR, and there are also other tools that might enhance AMPK. So it's sort of figuring out which pieces perhaps you need more than the other, and that's requires a little bit more individualization. Um, Rapamycin is certainly, in my experience, one of the tools in your toolbox, to get that done, and that's really the way we need to think about it. I think any particular intervention therapy, small molecule, um, needs to be think of it as in your toolbox. We want to we really want this is the magic pill, right? I mean, that's sort of the human nature, right?
Yeah.
This is the magic diet pill, lose weight, right? Only 19.99. It's like that's just not going to happen. And at this point, we you need to think of health and aging, as sort of this symphony, and of multiple instruments that need to play together, to create a score, to play a score for that particular person. So one person may require rapamycin in a larger amount, one person may require doing a number of other things in synchrony. That's a powerful way to vision it. And one piece does not, one instrument does not make an orchestra as well.
It may not be an answerable question, but if you were thinking, or if you were looking at someone, you're trying to set up a schedule for them, like a protocol, uh, what would you look for to say, well, would this person maybe someone for whom rapamycin would be appropriate?
um, I would look at age as a piece, right? So someone who's older, I would look at um, their ability to, or their desire or willingness to um, implement lifestyle dietary actions. Because I
Mhm.
think you can do a lot, if you're willing to pay attention to what you eat, and move frequently in particular ways, and do a little bit of fasting and actually monitoring your progress. I think there's a lot to be obtained from that without, I wouldn't say the risk, but with better understanding, because the body, and here's the thing, the body typically, it knows what to do better than we think we know what it should do. So anytime
Mhm.
we intervene, we're assuming, that we have it all figured out of what this particular molecule is going to do. And I would say almost all the time, will be incorrect. There'll be something like, so for example, there's a particular pathway that I just learned over the past few weeks that is a spin-off of some work that I do on mitochondrial function. It has to do with something called heme oxygenase and how the body recycles red cells into heme, bilirubin, and carbon monoxide. That heme oxygenase can be induced by a number of different molecules, and you need to be aware of what this carbon monoxide buildup is. And it's a whole nother conversation, but I had no clue, right?
Mm.
Literally had no idea, you know, that this existed. Maybe I forgot. I was never taught, so we all we all are exposed and have knowledge in particular areas, and we all can't know everything, right? There's
Hmm.
people who know very deep in one area. People are more widely based, and that's sort of where I tend to focus. But still, you're going to miss pathways. So when we start to intervene, we have to feel really comfortable that um, we're not missing something important, right?
Mm.
And so if you look at rapamycin and a work with a telehealth company advising them on protocols and the effects of rapamycin, if you look on rapamycin.news and you go, what benefits have you had? So the benefits typically are, I think it's about 40% have decrease in pain and inflammation. Maybe about 30% notice that they have more energy. Um, a lot of people say, about 20% they notice their athletic performance improves, and some don't notice anything. And actually, one of them, which is going to be a study, is they notice oral health improves. So rapamycin seems to have an effect on periodontal disease. Um,
Mm.
but then there's about 50% who don't notice anything. And a corollary is, okay, do you want more energy? We could give you caffeine or cocaine, right? Or a methamphetamine. You would have more energy. If I don't tell you what it is, but there's consequences of that, right? We want to knock your pain out. Let's say I had a stash of Vioxx. I could give you a Vioxx, but 3 years later, you might have cardiac disease. So we have to be careful of just saying that something makes us feel better, you know, doesn't have some other hidden unwanted effect that's going to show up at some later time,
Hmm.
right? And whenever we're throwing in a molecule that has um, an intervention, you know, in rapamycin, it's small, but there's still some unknown effects that we don't understand, right? And we need to monitor them, and I think that's the most important thing. But we can't monitor everything. So with anything we do, there's some risk, and as long as the benefits outweigh the risk, certainly letting metabolic disease or letting vascular disease or pain and aging, that's a known risk. So when you start to weigh the risk benefits and someone's not able or willing or has the time or knowledge to at least initially implement those lifestyle, diet, nutritional, mTOR controls, or not controls, habits or
Mm.
interventions, you know, you can jump on rapamycin a little bit sooner. Someone who's 75, you can, your risk benefit window is becoming, much lower at that point.
When once somebody has started rapamycin,
Uh-huh.
what would you look for to say, well, this isn't working or this is not appropriate for this person? Is there particular markers that you'd look for?
Yeah. Currently, there's obviously the most thing is someone having some unwanted effect, right? And you work through that, or not. So that's a key, and that may also be a consequence of dosing. So we'll leave that out for now because dose frequency. can make all the difference in the world depending on each person's need. And, I want, to stress that we can't listen to what someone else is taking and expect that that would be good for us, right? Because most of the time, even what someone else is taking in today's world is just what they heard someone else is taking, and there's a postulation. There's a bunch of trials out there right now, which is good, and it's going to give us some bigger signals of benefits in humans. But it's not individualized because randomly controlled trials are randomly controlled. So maybe you know I need to take for an optimal function 8 milligrams every 17 days. And Richard, you may find that 3 milligrams every 9 days is what best for you. There's a sweet spot. And if I put you on a higher dose and me on a lower dose, you may have a side effect and I'm not going to have any benefit. And we're going to say it failed. Well, it didn't fail. It's just we were put in the wrong group randomly.
Mhm.
And if you have a big enough group that it'll get washed away. But the other thing you're going to do is you're going to wash away the benefit. The net benefit is going to be weaker than if we had dialed in the exact dose for each person. So n equals one. We need the bigger studies to at least rule out large issues of concern or also large benefits
Mhm.
that we can be aware of. So if we're using a molecule for a particular purpose, right? Like we may find rapamycin may be really good if someone has a disease. So there's a difference, right? Are we using it to treat a specific dysfunction or pathology? So good to know that if someone has cardiomyopathy, that perhaps this is a tool that you might want to consider to try. And I know someone that used rapamycin with cardiomyopathy, and they had a dramatic response. It's an n equals one, but okay, our
Mhm.
heart's our heart's function. It was significantly down, and now it's better. So did that do it? I don't know, but it was one of two things that she did, and you wouldn't expect that normally to recover the way it did. Um, so if you're looking for it to prevent against cancer, so you have more of a time. I think that's in my mind as a clinician. It's like, how are you suffering? You know, and do we have time to play around with things? So if you're doing something for health span and lifespan, that implicitly says you're going to be on it for a long period of time. So take a breath, say, okay, this is a tool in my basket. I want to consider it. Maybe it's appropriate for me now. So begin to then look at markers. And, as we talked about, um, one of the key markers is mTOR, AMPK, and that gets down to mitochondrial health. So begin to understand how that's affecting your mitochondrial health. In a perfect world, we would have at, at, an at-home PCR test that we could check our blood and look at mitochondrial function and some of the electron transport chains. We don't have that yet, but there's a lab in Germany that's doing mitochondrial function. We can start to get a sense of that, and that's one thing we'll be looking at. But it's a blood drop sending it to Germany. That's it's not inexpensive. It's 300-400 bucks or so forth, but not crazy expensive on something. Um, Metabolically, okay, are you losing visceral fat? Are you gaining muscle? That's something that's easy to do. What's your sleep metrics? Are you sleeping deeper? Um, we're going to be looking at even what I mentioned, carbon monoxide. There's a way perhaps to look at what rapamycin is doing to a few pathways and actually measuring carbon monoxide through breath. There's devices where you'll be able to do that. And there's a link to mitochondrial function and metabolism and circadian temperature. So there's data and studies on this as well. But when we're metabolically dysfunctional, we tend to have a lower body temperature. When you're metabolically healthier, body temperature tends to rise, right? And that may have to do with muscle mass, and certainly part of it. Like we were hiking yesterday and it wasn't too cold. It was like 48 degrees, right? My son, who's very lean and muscular, and then this other guy are in shorts and t-shirts, right? And my son's girlfriend's wearing a scarf and a wool cap and a puffy coat and a jacket. And she's pretty much, she's muscular, but it's at a different level. So muscularity, and I'm sort of in between. I didn't have a coat on. I just had sort of a long sleeve shirt on and I was fine. So the more muscle mass, the more mitochondria, the more heat. Mitochondria they can power up to 50 C, like crazy heat um, ability. So the more the better they're functioning, the more you have, the warmer you're going to be, the higher your body temperature is. And there's many factors in there, but it's a gross factor. Flipping that though, part of fasting and part of lifespan is actually perhaps a lower body temperature. But I think it's even more than that.
Yes.
I think it's, in speaking to someone in the past week, it's the spread. It may not be, and it gets back to flexibility. It's probably not good to be low all the time.
Hmm.
So there's a researcher who was telling me what they're seeing is using circadian, and there's devices now, so you don't have to do an oral temperature. You can put a little device on, and it measures heat transfer through the body and gives you an active marker of your body temperature. And you get a little app, and you can see every minute to 5 minutes, depending on which level of device you have, what your temperature has been through the day. And then you can start to correlate that with things that you do. A really healthy metabolism should have a wide spread. It should be very low at night and it should be higher in the day. And that's one that can cycle back and forth. And that's that hormetic resilience, flexibility that we're talking about. I haven't done this yet, but I've looked at some of the data and I suspect that we'll be able to use that cycling as perhaps a super simple way to understand dosing of rapamycin and mTOR flexibility. Because if we're suppressing you too much, that's not good. If you're taking it the wrong time and you're inducing a particular pathway that we don't want, you may see temperature go up. So that would be, I'm really super stoked on that because that's something you could do at home. And maybe we see that um, for the first few days after taking rapamycin, there's a particular signal and then it phases out, which then lets you know that perhaps it's time to go again, right? Because and things that are unknown, we could spend a lot of time about this is do you want to peak? You know, you, there's rapamycin, there's rapamycin that needs to get into the body, into the bloodstream, but ultimately we want to know how it affects mTOR, right? So, if you think about it, there's the formulation of rapamycin or sirolimus that you're using. It's how you're absorbing it. It's what's your genetic capabilities to break it down. So, one simple way could be, okay, we're going to look at serum levels of rapamycin and see what's your peak level, what's your level in 4 days, and then perhaps at what point does it clear a threshold where we know it's basically out of your system. That doesn't tell us specifically how it's affecting your mTOR, right? Because maybe you
Mm.
need a higher signal for whatever reason. You're more mTOR resistant, and so ultimately at the end of the day, we need some phenotypic marker. We can do the biochemistry. We can look at this, and it's certainly anyone on rapamycin should do as a baseline for a test, like an omic age through True Diagnostic is a nice global marker. Again, people could debate the benefits of DNA methylation as a marker, but their new omic response and the Dunedin pace, if you're absolutely going in the wrong direction, then you need to rethink it, right? Um, I'm not I'm not sure I'm hanging my hat on someone with a 0.72 is the Dunedin pace is that feel good about it for sure. But it's not our end all be all marker that we want to look at. And those are coming, like some of the telomics is doing, is looking at protein markers for all the different organ systems. And as we get into, quantum computing in the next 4 or 5 years, the ability to look through proteins is just, it'll be like reading a large page type in a book, a children's book for that system, and the amount of information it will be able to understand, is just going to dramatically increase. But even now, we're getting much better at understanding those signals. But even with that, we need to be able to marker, something. So circadian temperature is really important. Visceral fat, muscle, um, insulin response, right? Is your insulin going in the wrong way? Is your blood pressure going in the wrong way? These are all signs that maybe something is not quite balanced. And part of that, and it gets even murkier, is you're familiar with the mTOR1 and mTOR2
Mm-hmm.
enzyme, right? So there's two complexes. The mTOR1 complex is the one that is the primary energy sensor, in the body. And that's the one that's going to stimulate autophagy and mitophagy and reduce the hyperfunction aspects of mTOR. The mTOR2 complex seems to be the one that, when we suppress, while there may be arguably some benefit to short-term suppression, keeping mTOR2 higher is a good thing. And here's the interesting thing I came across: fasting and anything that's AMPK driven drives mTOR2 up, right? So um, the problem with rapamycin, or which we'll call an early rapalog, is if the dosing isn't right, if perhaps your sensitivity or your basic biochemistry, it may suppress mTOR2 more powerfully than you want it. So now you've got this enzyme system which has been just not destroyed, but just disabled, right? So when you use rapamycin for immune suppressing, which is what originally came out, that was the goal, right? It was to take a high dose to disable mTOR2 so you would not have an immune reaction to this foreign body in your tissues. That's not a positive thing if we're looking at it for Healthspan. So what we've learned is if you take a lower dose and you pulse it and you let mTOR2 recover, the consequences of that immune suppression, don't exist. And in fact, through Joan Manick studies, they show, especially in older population, that immune response can actually improve. So it's a dose, it's a frequency, it's an aging. Um, Tornado and Joan Manick's company is coming out with new rapalogs that will be much more specific and targeted to mTOR1, which is awesome. And that may alleviate some of the concerns that we have, with dosing, and allow us to be more, maybe perhaps aggressive and even more effective. The problem, and we'll see. Anyway, Krister Capaway, for if you're interested, Master One Thing, has interviewed a bunch of people on rapamycin. He's interviewing Joan Manick, and the concern is, they're doing small molecules for disease, cancer, immune disease, skin diseases, and so forth, not aging. So, what's the price in this going to be, right?
Mm.
Rapamycin you can get for $1.25 a milligram. Currently, Pfizer's sirolimus is like 60, right? So even though there's a competition, it's 50 times the price. I can't imagine what, it could be $1,000 a month or more, when these new molecules get approved, which make it not not commercially available for the longevity space. Some people will,
Yeah.
have the means, but for the most of us, we're not going to do that. We're going to say, all right, I'll stick with rapamycin. So, um, So there's those nuances. It's that mTOR one, mTOR two, which for me, currently, I favor longer cycles. Until proven otherwise. Like I favor every 2 weeks. I'd rather, again, till proven otherwise, until each person's individual data, or there were some really strong case of some randomly controlled trial that said this seems to work way better in larger groups. So you start with that. But for me, let's start a little more conservative, go 2 weeks, and or even start low and then build out your frequency. Let mTOR2 recover, right? Because that mTOR2, when it's suppressed, is you start to see metabolic dysfunction, and you do see that in some people. You see their insulin going up. You see the triglyceride HDL ratios going down. Um, you know, so the question clinically, I say, well, that's not good, right? If I saw someone with that response, it's like I'm not happy with that.
Mm.
So is the fix taking a carbose or metformin or berberine to um, counteract that metabolic dysfunction? Is that all we're doing, or is there some unknown other consequence of rapamycin, and we're just covering up some numbers, right? to
Yeah.
to make them better with a polypharmacy. I'm not clear on that, and so that's why we need to look broad at a variety of different markers and making sure that the majority are going in the right direction.
Interesting. So, so when you're working with people, it's like you take this fairly wide view of all their markers, and you see how they change when they have rapamycin. Uh,
Correct. And getting back, and I think the other theory I have, and haven't tested it out, there may be a way to use. I have an mTOR I have an mTOR cycling protocol that I built out as a first draft, and I'm happy to share that and have feedback from
mhm,
anyone with really good knowledge, because it's really just a working theory based on my experience and knowledge. And obviously the more we can tweak this, but just from a simplistic point of view, I was wondering if fasting improves AMPK and AMPK improves mTOR2. What if someone took rapamycin and then at some point in that first week did a short little fast? I don't know how long it might be. Is it 36 hours? Would that be enough? Would that be enough to have an MPK drive to counteract that mTOR2 suppression and just sort of reverse it? And that may
mm,
eliminate someone's mTOR2 problems from rapamycin and clear that out. So I throw that out to anyone who's using rapamycin who's seen metabolic effects to consider, that process. I always say stretch it out. Don't redose. Don't redose in a week if you haven't, one, checked your levels to know where your sirolimus levels are at least. We'll get smarter with temperature, but
mhm.
also consider stretching out your frequency and doing a short fast and seeing if that made a difference.